everyone, welcome to another episode of Clinical Case Discussion. Today we are going to see one of my most favorite topics, goiter. As for any other case, first we will look at the basics. Please understand there is no clinical subject without any fundamentals. So we need to understand the basic anatomy and physiology related to thyroid gland. Then we can understand the clinical points related to thyroid gland swelling very properly, right? So let's start. So the first one is thyroid gland is the first endocrine gland to start functioning in fetus at around 10th week. So it is the largest endocrine gland. It is the only endocrine gland which can be palpated with our hands when enlarged. And it is very highly vascular. We will discuss about this last point when we are going to talk about operative surgery. So the story of thyroid gland begins from a structure called foramen cecum. So as you can see here, foramen cecum is an important structure present between tuberculum impar. So this is the foramen cecum. This is a small hole present between two important structures. One is tuberculum impar and another one is copula. So this foramen cecum, at the level of this foramen cecum, there develops an endodermal thickening. Please understand, thyroid is endodermal in origin. So it's an endodermal thickening which will continue to descend in the form of a tubular structure called thyroglossal duct. Just understand the terminology. Thyroid, glossus means tongue. So at the base of the tongue, this foramen cecum is present. From there, this thyroglossal duct descends. So the thyroglossal duct becomes a solid structure at around fifth week of gestation, after which it will fragment and disappears. This is the normal fate of thyroglossal duct. We will see what happens if there is any patent thyroglossal duct and what will happen in the subsequent slides. So as the thyroglossal duct descends down, at one point of time it will bifurcate, and slowly there will be formation of thyroid parenchyma, that is nothing but your follicular cells. So this is called median unlage. So there are two types of unlage. Unlage is nothing but an embryological origin part. Okay, so this is median unlage and this is your lateral unlage. So the median unlock is nothing but your thyroglossal duct that will be forming follicular cells of thyroid gland. So the thyroid will continue to descend to its final position anterior to the trachea by 7th week of gestation. Okay, right. Then by around 10th week of gestation, the thyroid follicular cells are fully functional and they'll start producing thyroid hormone. That is why I told you thyroid gland is the first endocrine gland which will start functioning in the fetal life. Okay, right. Next. So this is the course of the embryology of thyroid gland. It starts at the level of foramen cecum, then it will slowly descend down. Then at the level of hyoid bone, it will take a little bit left turn, and again it will continue to descend to ultimately reach its position anterior to the trachea. Now, what will happen if there is any patency of the thyroglossal duct? Sometimes what can happen, what are all the abnormalities during the embryology is that sometimes there can be arrest of this descent at the level of tongue itself. So, in such cases, you can observe or you can have the patient will be presenting with a swelling at the level of base of tongue. That is called lingual thyroid. I'll show you the picture in the subsequent slide. Then very rarely, normally thyroglossal duct should get obliterated. If at all there is any patency, there can be, this particular thyroglossal tract is lined by pseudostratified columnar epithelium. So pseudostratified columnar epithelium with goblet cells and all will be there. So what does this epithelium do? It will start secreting mucin slowly, and it takes around 10 to 12 years to form the cystic swelling, that is nothing but your thyroglossal cyst. That is why even though thyroglossal cyst is a congenital condition, but clinical manifestation will be happening at around at the end of first decade or in the second decade. Why is it taking so much time? Because this mucin secretion takes time. Very slowly it will get accumulated in that particular swelling, and then it will manifest as a swelling at the level of a hyoid region. And the most common location of this thyroglossal duct, thyroglossal cyst is, so most common location is nothing but your subhyoid or infrahyoid. It can happen anywhere along this path of the descent, but most commonly it is seen at the subhyoid region. Okay, or it can get arrested at anywhere else also. In such case, it will form ectopic thyroid. Okay, right. Next. So this is the clinical picture of a thyroglossal duct. You can see here at the level of upper midline neck, you are having a cystic swelling present there. What happens if you don't treat a thyroglossal cyst or the patient didn't care much about it? So ultimately, at one point of time, it can rupture and it will form fistula, thyroglossal fistula. Please understand, thyroglossal cyst is always congenital, whereas thyroglossal fistula is always acquired. Okay, right. So this is the important pathologies related to embryology of thyroid gland. Next. So this was the lingual thyroid we were talking about. The patient presents with the swelling at the base of tongue if he or she observes carefully. And another complaint which the patient can present to you with is there is difficulty in swallowing because of the particular enlargement in the base of the tongue. There may be little bit difficulty in speaking or even in swallowing the food also, right? So this is the swelling that is present at the level of base of tongue, right? In clinically, when we are evaluating this lingual thyroid, we must always do ultrasound neck to confirm that like there is a normal thyroid gland, whether it is present in the thyroid fossa or not, because sometimes this lingual thyroid is the only thyroid tissue present in the body. So we need to be careful little bit about that. Okay, right. Next, coming to anatomical disposition. So thyroid gland is present between C5 to T1 vertebral level, and isthmus of the thyroid gland lies at the level of second, third, fourth tracheal rings. Okay, and it has got two lobes and one isthmus. Rarely you can have a caudal remnant of this thyroglossal duct in the form of a pyramidal lobe. Okay, right. Then please understand there is one important structure. This thyroid gland is enclosed within the fascia, which is nothing but pretracheal fascia. So this pretracheal fascia, this red color dotted line is nothing but your thyroid gland. So you need to understand this thyroid gland is enclosed in the pretracheal fascia, and the anatomical disposition will be important to understand few clinical entities like why does the thyroid gland move up with deglutition, etc. We will see them in subsequent slides. Please understand at the level of superior lobe of the superior pole of the thyroid lobe, you have one important nerve called external laryngeal nerve, what we call EBSLN, external branch of superior laryngeal nerve at the level of superior thyroid artery. Okay, right. We will see the clinical importance subsequently. Next. So just like we have got external laryngeal nerve at the level of superior pole, we have got one important nerve at the level of inferior pole or in the tracheoesophageal groove, that is nothing but your RLN, recurrent laryngeal nerve. Okay, right. Next. So what is the arterial supply of thyroid gland? Arterial supply. So there are two important arteries which will be supplying on either side. So one is superior thyroid artery, second one is inferior thyroid artery. So superior thyroid artery is a branch of, you can see here, sorry. So this is your internal carotid artery, this is your external carotid artery. So from the external carotid artery, so you can see here, this is the external carotid artery. From the external carotid artery, you have got superior thyroid artery, and it is a major blood supply to the 80% of the thyroid gland has got its blood supply from the superior thyroid artery, right? Next, inferior thyroid artery. It is a branch of thyrocervical trunk. You can see here, this is the thyrocervical trunk, which in turn it's a branch of subclavian artery, first part. So subclavian artery has got three parts by the scalenus anterior muscle. So, and first part, second part, third part. This thyrocervical trunk is a branch of first part of subclavian artery. From the thyrocervical trunk, you have got inferior thyroid artery. Please understand another important point. Inferior thyroid artery is the one which will supplies to all four parathyroid glands. All four parathyroid glands are supplied by this inferior thyroid artery. Okay, very rarely you can get, in very few people you can get something called thyroidia ima artery, which is a branch of arch of aorta, right? So this is about arterial supply of thyroid gland. What is the clinical importance that we need to understand whenever we are checking for any bruit present in auscultation in case of a thyroid gland swelling? We will check it at the level of superior pole of thyroid gland. Why is it so? There are three important reasons for that. we will discuss in clinical part, this examination part. First one is superior thyroid artery is the major blood supply of thyroid gland. Second one, it is a direct branch of external carotid artery and it is present more superficial. So it is easy to check for the bruit at the level of superior pole of thyroid gland. The examiner can ask you why not inferior pole. Inferior pole, the inferior thyroid artery supplies only less amount of blood supply to the thyroid gland. And another important clinical point we need to understand is, as you can see here in the picture, it goes behind the common carotid artery. So this is the common carotid artery. Inferior thyroid artery goes behind the this common carotid artery. It is little bit deep when compared to superior thyroid artery. That is why it is difficult to examine for bruit in inferior pole of the gland, right? So you need to understand one, the bottom line is bruit in case of a thyroid gland is checked at the superior pole of thyroid swelling, right? Next. So coming to venous drainage, again, three important veins we need to understand: superior thyroid vein, middle thyroid vein, then is inferior thyroid vein. Okay, right. So this is inferior thyroid vein. Superior thyroid vein and middle thyroid vein both will drain into internal jugular vein. Whereas you can see here both inferior thyroid veins usually they will drain into left brachiocephalic vein. Right? What is the clinical importance of middle thyroid vein? Please understand, whenever we are doing thyroidectomy, once we open the pretracheal fascia, the next thing you are going to see is your thyroid gland. So the first vessel to be ligated during the thyroid surgery is middle thyroid vein. So it is the first vessel to be ligated during the thyroidectomy. Okay, right. Next. This is important only for postgraduates. So there is one important anatomical space called space of Reeves. What is space of Reeves? It is nothing but it is an avascular space present between the upper pole of the thyroid gland and the cricothyroid muscle. You can see here, this is the cricothyroid muscle and this is the upper pole of the thyroid gland. What is its clinical importance? It is very safe to dissect or ligate the superior thyroid artery. It is important to avoid the external laryngeal nerve injury. You need to always look at the external laryngeal nerve and preserve it carefully. Okay, so you can see here this superior pole of the thyroid lobe is pulled down and out. Okay, nothing but inferior and laterally. So this maneuver of pulling the superior pole of the thyroid gland gently down and out to expose, to look at the space of Reeves. This maneuver is called Nyhus maneuver. This is important for postgraduates. What is Nyhus maneuver? It is nothing but pulling the superior pole of the thyroid down and out to demonstrate, to look at the external annulum, to visualize the space of Reeves. Right? Next. Again, this is important for postgraduates. There is something called Cernia classification, very important. This is nothing but for external branch of superior laryngeal nerve crossing the superior pole. So I told you we will see the nerves related to thyroidectomy and all. So EBSLN is very important to maintain the pitch of the voice. So we need to preserve EBSLN very carefully. Now the anatomical extent or the anatomical location of this external branch of superior laryngeal nerve comes under three types. One is type 1, type 2A, type 2B. Type 1 is nothing but if this is the superior pole of the thyroid, you can see in the picture here, the external nerve is present, the gap between external nerve and superior pole will be more than 1 centimeter. So more than 1 centimeter from the superior pole. Whereas in case of type 2, there is only less than 1 centimeter gap. Less than 1 centimeter gap between superior pole of the thyroid and external branch of superior laryngeal nerve. Whereas in type 2B, you can see here in the picture, the nerve is passing below the superior pole of the thyroid gland. Now you need to understand, usually when we are ligating the superior thyroid pedicle, we will we will be ligating at the level of superior pole, just above the level of superior pole. That is why type 2A has got the highest risk of chance of injuring the EBSLN. Okay. So one important point we need to understand is type 2A of Sarnia classification has got highest risk of EBSLN injury. Right. Next. This is very important to understand. Vagus nerve will be having two parts. One is recurrent laryngeal nerve and superior laryngeal nerve. This recurrent laryngeal nerve is also called inferior laryngeal nerve. Okay. Now this right side, it will go descend down. It will hook around the right subclavian artery, and it will take a retrograde fashion. It will travel in a retrograde fashion to supply the muscles of vocal cords. Whereas left side, it will hook. It will descend a little bit down, and it will hook around the ligamentum arteriosum at the level of arch of aorta. Then it takes a turn again in the tracheoesophageal groove. It will travel and it will supply the muscles of vocal cord. Okay. Please understand, recurrent laryngeal is a mixed nerve. So the muscle motor supply is for all intrinsic muscles of larynx except cricothyroid. And this cricothyroid will be supplied by your EBSLN. Okay, right. And recurrent laryngeal is sensory for the all the vocal cords on the larynx below the level of vocal cords. It is below the level of vocal cords, right? Coming to superior laryngeal nerve. Again, superior laryngeal nerve is divided into two things: EBSLN and ILN. External branch and internal branch. Internal laryngeal nerve, external laryngeal nerve. External laryngeal nerve is also called singer's nerve because it is very essential to maintain the pitch of the voice. Okay, so this supplies the cricothyroid muscle, and internal laryngeal nerve is a pure sensory, and it is supplying the mucous membrane above the level of vocal cords. Okay, so this is the now these are the nerves related to thyroidectomy. I told you EBSL is very important when we are ligating the superior thyroid pedicle, whereas recurrent glandular we need to be careful when we are dealing with the dissection at the inferior pole or at the level of lateral aspect. Okay, right. Next, we will see what happens if someone accidentally damages any of these nerves in the operative surgery part. Right. Next, coming to the lymphatic drainage, please understand any midline structure in the body has got bilateral lymphatic drainage. Here also, mainly prelaryngeal lymph nodes. In fact, prelaryngeal lymph node, which is also called Delphian lymph node. Delphian node. This is the sentinel node of thyroid cancer. So this is the sentinel node. Sentinel node is nothing but the first lymph node which will be draining the tumor. Okay, right. As you can see here, whenever there is a thyroid cancer, it can go to lateral level of lateral neck nodes, that is jugular digastric nodes. And here you have got retrosternal. Very rarely it can go there. Pretracheal, prelaryngeal, and jugular-digastric, jugulo-omohyoid. These are the important lymph nodes related to the thyroid lymphatic drainage. Right. Next. So one important question the examiner can ask you is, what are the different levels of cervical lymph nodes? Levels of cervical lymph nodes. Okay, right. You can see here 1A is submental, 1B is submandibular. Submandibular is also called submaxillary. Okay, so 1A is submental, 1B is submandibular or submaxillary, both are same. Then level 2 is upper jugular, level 3 is middle jugular, level 4 is lower jugular. These are also called deep cervical lymph nodes. Okay, as you can see, this muscle is nothing but your sternocleidomastoid muscle. Posterior to the sternocleidomastoid is your posterior triangle of the neck. So level 5 is nothing but posterior group of nodes, posterior group lymph nodes. And level 6 is your pretracheal, prelaryngeal, pretracheal and prelaryngeal. Then level 7 is nothing but your anterior mediastinal lymph nodes. So these are the important 7 levels of cervical lymph nodes. Right. Next. Coming to the nerve supply of thyroid gland, mainly it is deriving its sympathetic supply from the middle cervical ganglion and partly from the superior and inferior cervical ganglion. One important anatomy point the examiner can ask you here is, what is stellate ganglion? What is stellate ganglion? Please understand, in cervical sympathetic ganglia, there are three important cervical sympathetic ganglia: superior, middle, and inferior. Okay, so superior, middle, and inferior. These are all cervical sympathetic chain, cervical sympathetic ganglia. Now, what happens in most of the patients, usually in majority of the patients, the inferior cervical ganglion will fuse with this first thoracic ganglion, and it will form something called a star shaped ganglion like this. So it is nothing but a mixture, a fusion of inferior cervical ganglion along with the first thoracic sympathetic ganglion. Okay, so fusion of inferior cervical sympathetic ganglion with first thoracic sympathetic ganglion, it will form a star-shaped ganglion that is called stellate ganglion. Okay, so you can see here. So this is the middle inferior cervical ganglion along with the first thoracic sympathetic ganglion forms the stellate ganglion. Right. Next, very important anatomy point we need to understand so that we can better understand the history related to the complications in case of a thyroid swelling is nothing but your anatomical disposition of deep cervical fascia. It's a very favorite question of examiners. At the level of thyroid gland, what is happening to the deep cervical fascia? You know that deep cervical fascia has got three important layers. One is pretracheal layer. You can see here, this is the pretracheal fascia. Second layer is pre Last one is your prevertebral fascia. First one is investing layer of deep cervical fascia. So this is the first one. Pretracheal fascia is the second one. Last one is prevertebral fascia. Okay. Now, investing layer of the deep cervical fascia is very anteriorly present. In fact, you need to understand what are the layers present here from superficial to deep when we are doing the thyroidectomy. First one is skin. Just beneath the skin, you have got subcutaneous muscle, nothing but your platysma. After platysma, once you raise the subplatysmal flaps, you have got this investing layer. So this is second. When we are dissecting the layers, this is the third one. Once you dissect the investing layer of deep cervical fascia in midline, all you have got is nothing but your strap muscles. So I'll tell you what are strap muscles and how is it important. Then after the strap muscles, next is nothing but your pretracheal fascia. So fifth one is your pretracheal fascia. Then once you open the pretracheal fascia, as you can see here, this is the thyroid gland we have. Okay, right. Then what are the important strap muscles we need to understand? This is a favorite question of examiners again. So strap muscles, you can remember with the help of a mnemonic TOSS, TOSS. So T for thyrohyoid, O for omohyoid, S for sternohyoid. Last one is sternothyroid. Okay, these are the important four strap muscles which are also called ribbon muscles. I mean infrahyoid ribbon muscles or strap muscles. Now you need to understand what are the strap muscles which are present superficially, what are the strap muscles which is present little bit deep. So the first one you can see here, medially you have got sternohyoid. Laterally you have got omohyoid superior belly. Okay, so this is medial. You can see here in the picture, this is the midline, this is medial, this is lateral. So after these two layers, superficial layer of strap muscles, beneath the first layer you have got a sternothyroid. So this is nothing but your sternothyroid. You can see here, deep layer, second layer is your sternothyroid. You can easily remember H comes first, then T. T comes next in alphabetical order. Okay. So sternohyoid, sternothyroid. It is extending between sternum and thyroid cartilage. Sternohyoid, from sternum to hyoid bone. Okay, right. Coming to thyroid histology, you know thyroid follicle. There is the functional unit or the main important structure that is required here is something called thyroid follicular cell or thyroid follicle. In the thyroid follicle, you have got a cuboidal epithelium. In resting state, it will be cuboidal, and in active state, it will be columnar epithelium. So this particular one single cell is nothing but your follicular cell. Follicular cell. You can see here pinkish material here, that is nothing but colloid. Okay, colloid is nothing but the storehouse of thyroid hormone. Right. Next, very important, thyroid physiology. It is very essential to understand thyroid physiology. I have made a separate video. I'll give the link in description. Please go and watch that video. So in one single diagram, you can understand the physiology of thyroid hormone synthesis and also anti-thyroid drugs, two important diseases, autoimmune diseases in thyroid pathology. Okay. This one essential diagram, this one important diagram is very essential to understand and remember so that we can understand the antithyroid drugs and two important thyroid pathologies. Okay, right. Next, Few important points from thyroid physiology is that in the follicular cell, once the thyroglobulin has been transferred from, this is the lumen actually, this is the basolateral membrane, and this is apical membrane. This one is apical membrane, this one is basolateral membrane. In from the lumen, once it comes into the follicular cell, there your T3 and T4 are separated. You can see here T3 T4 being separated, and they are secreted into the blood circulation. You have the blood vessel here normally. So imagine this is the blood vessel you have. Into the blood circulation, your T3 and T4 are released. Okay, so once they are released into the circulation, they are not free. They will be binding to, there are certain binding proteins to which this T3 and T4 will get bound. Okay, so what are the important binding proteins? One is albumin, second one is prealbumin. There is another one which is called thyroid binding globulin. Okay, so these are the three important binding proteins to which this T3 and T4 are bound. This prealbumin is also called transthyretin. Okay, right. So you can see here albumin, thyroid binding protein or thyroid binding globulin. So normally free T4 is present 0.03%, whereas free T3 is present somewhere 0.3%, and the T half of this T4 is 7 days. Whereas T half of free T3 is nothing but, or T3 is 1 day. This is the actual active form. That is why whenever thyroid hormone is going to act on the periphery, this T4 will get deiodinase to T3 at the periphery with the help of an enzyme called deiodinase. Okay, right. And this deiodinase, it is of two types, deiodinase 1 and deiodinase 2. Important for postgraduates. This deiodinase 5-deiodinase 2 deficiency will result in euthyroid sick syndrome, which is also called sick euthyroid state. Okay, right. Now coming to few important definitions in thyroid gland swelling. One is goiter. Any enlargement of thyroid gland, any enlargement of thyroid gland, irrespective of pathology, irrespective of pathology, is called goiter. Second one is solitary thyroid nodule. It is nothing but a discrete, nothing but a single palpable nodule with rest of the thyroid gland impalpable. Only one nodule is palpable, that's it. Rest of the thyroid gland is normal, it is not enlarged. Multinodular goiter means multiple nodules palpable with rest of the thyroid gland palpable.